Hello, and welcome to Mapping Health and Illness Across Societies within the Health and Social Sciences courses. And this lecture is given by myself, Dr. Sean McLaughlin, and I'm going to be talking to you today about mapping epidemics across societies. In this section, I'm going to briefly introduce some of the topics in the lecture. Particularly, we will be looking overall at the social impact of epidemics of infectious diseases. And to back some of this up, looking at the development of public health methods in the 19th century and some of the discoveries that informed this era, including Darwin's discovery of evolutionary theory and speciation. I will also be looking at how biological and social determinants are implicated in HIV epidemic control, and then talk you through some methods of modeling the social aspects within HIV treatment and care. And in this new age of the digital and scientific revolution, we are now looking at molecular epidemiology as a mainstay of the epidemic control measures, and part of this lecture will be deconstructing some of the social implications of those methods and situating the social evidence from these studies within theoretical discourses such as biopower and the deconstructivist paradigm. And then how we translate social reality into qualitative analysis? What methods can we use to transcribe this material into our records and publications and academic content? So just to look at the scale of the epidemic of HIV globally in 2023, the UNAIDS and World Health Organization estimated that 39.9 million people were living with HIV. And of that, in that year, 2023, 630,000 people were supposed to have died, and estimated to have died from HIV-related causes, whilst 30.7 million people rather were living with HIV and receiving antiretrovirals. To look at this case study, which I'm going to focus on today in South Africa, this 2024 HIV country profile from the World Health Organization cites the population of South Africa as 63.2 million people, with about 7,400,000 people known to be living with HIV and nearly 6 million people receiving antiretrovirals. So just to look very briefly at the development of public health methods, starting with the landmark shift with John Sutherland, a graduate of Edinburgh University, who isolated an outbreak of cholera in Hope Street in Salford, which was a paradigm shift in terms of how epidemiological methods were used to survey houses that were infected with the cholera outbreak and then isolate the pump that was providing water within which the infected agent was detected. And this really begins the public health methodology with mapping out individuals and communities, contact tracing their movements around the infectious agent. And it fits into an era when there was a particular concern with social reform, poverty alleviation, and intensifying scientific focus on class and necessity and the relationship between individual and society, which we'll look at more in terms of sociological theory later in the lecture. And it also coincides with a period of greater scientific rigor to medical and nursing practice. We have better surgical methods, more hygienic medical practice and nursing methods, and new technologies like the stethoscope, and an intensified interest and development of microbiological techniques such as Robert Koch, who won the Nobel Prize, and particularly relevant to this topic. So if we're to look at how this has developed into the 20th century and then certainly now still underlying our 21st century approach to epidemic control. In terms of HIV, this kind of sexual network analysis would situate, as you can see from the diagram, groups of individuals within subgroups of risk and according to high risk and low risk behaviors. And this really begins to typify the approach to HIV in the particularly the 80s, when HIV was seen as confined to subgroups of men having sex with men, commercial sex workers, and intravenous drug users in the United States, and then subsequently in Europe. And these high-risk groups would have been sought to be identified by public health measures and then being targeted for prevention and treatment. So high numbers of sexual partners or risky sex without protection and travel, frequent travel, were all seen as high-risk behaviors, whereas monogamy and abstinence or the use of prevention was seen as low risk. And these become mainstays of our epidemic control measures, not just for sexually transmitted diseases, but they have their parallels in terms of airborne infections. So how might we start to transform this social data into the modeling of HIV treatment and care? In this study that I participated in, we looked at the group of women and children who had received antiretrovirals at the local children's hospital moving back into their communities, and the experiences that they had there, which we were able to interview them in their communities, and some of the salient issues which occur often in these kind of studies, issues around stigma towards the women and their children, fears about being referred to the local clinic from what they perceived to be the safer environment of the children's hospital as they were down referred into their community and back into the family environment, issues around disclosure and attitudes from neighbors which might be damaging to themselves and their ongoing adherence to antiretrovirals. Another sphere looks at socioeconomic factors and the cost of maintaining these antiretroviral regimens in association with good food, the burden falling on the mothers and their close kin, and these kind of socioeconomic income determinants that underlie some of the measures and their success in terms of HIV treatment. So using this kind of So how do we situate this evidence within social discourses and broader theoretical discourses? How might we put together our evidence from the pediatric cohorts and the testimonials of the women and children with other evidence from the HIV field, such as sexual network theory and the implications of contact tracing for these women and their children in unsafe communities? And in this sense, somebody like Didier Fassin, looking at the epidemic in South Africa, might point to the influence of biopower and its reach into communities and homes from the level of ANC politics at the national governance to international policies and influences in a kind of nascent form of biopolitics that potentizes the discourses around these individuals and the products of the laboratories and hospitals. And we might want to generate a theoretical model such as this one, drawing on the spheres in the qualitative study of the pediatric cohort, using the same kind of Venn diagram but translating it into various ideas around the notion of therapeutic citizenship and responses to biopower, of individuals being shaped by their experience of the hospital and shaped by their contact with biomedicine, but returning to communities where they may need to, for political or cultural reasons, hold to a different paradigm of healing or um, allegiance. And so we may have one environment where orthodox therapeutic citizenship is illegitimated, and in another environment like the community, they may be a license to be alternative or ambivalent towards those influences.